Boleh dong. Betul begitu. Kalau kamu masa tunggu cukur.
Can we start?
Yes.
Okay.
Please.
Hi, everyone. Welcome to the APSC call webinar entitled Standardized Medicine of Cardiogenic Shock with or without cardiac arrest. I'm Dr. Xu from Xinguang Memorial Hospital, Taipei, Taiwan. I will chair this webinar. Okay, next. So cardiogenic shock is a catastrophic condition with a high mortality rate. The SCAI shock classification system is developed and revised to accommodate the dynamic and often sudden deteriorating conditions in cardiogenic shock. During the evolution from SCAI shock stage ABCDE, invasive hemodynamic and laboratory monitoring, selection of in-time inotropes or inodilators, implantation of Impella axial flow or VA-ECMO, centrifugal flow, and even the addition of early active LV unloading in VA-ECMO will need to be intensive and frequently evaluated to install so as to reverse the cardiogenic shock from progressive deterioration and then possibly complete recovery. This I am there. Okay, next. So the content of this webinar is copyrighted by APSC and should not be distributed without the prior permission of the APSC. And the live streaming content of this webinar will be made available via APSC Cloud, APSC Facebook, or YouTube page. Okay, let's get started. Anyway, after each speaker's talk, we have a short time Q&A. The first speaker is Kendra Manny Porter from Nepal. Dr. Porter is an associate professor and interventional cardiologist at the Department of Cardiology, Mannahan Cardiothoracic Vascular and Transplant Center, Tribal Human University, Kathmandu, Nepal. The title of his talk is Shock Staging by the Revised SCAI Shock Classification Pyramid, a team-based approach. Let's welcome Dr. Porter.
Can you hear me? Very
okay.
warm good morning to all, respected chairperson and my dear colleagues. Today, in this 20 minutes, I'm going to present on shock staging by revised SCAI classification, shock classification pyramid, a team-based approach. So there is nothing to declare. The SCAI classification of shock has been developed and released in 2019, and it has been endorsed by different societies because it is simple and is being increasingly incorporated by different societies. The American Heart Association, American College of Cardiology, the Society of Critical Care Medicine, and the Thoracic Society was in April 2019. So the development of this classification in 2019 has been reviewed, and then it has been tested by different validation studies, and the draft manuscript was peer-reviewed in October 2021, and the document was revised to address the pertinent comments. The SCAI Publication Committee and Executive Committee endorsed the document as official society guidance in December 2021. And the purpose is to help clinicians make decisions about the treatment alternative of cardiogenic shock. So this is the origin, this is the pyramid showing the original SCAI classification, and it started from A to E. A is at risk, B is the beginning, C the classic shock, D deteriorating, and E is the extreme. So the A at risk means suppose a patient is having myocardial infarction and no sign and symptom of shock. B, if the patient is compensated with tachycardia and hypotension. C, if the patient is having perfusion problem, which can be detected by increasing lactate or creatinine. The D stage means deteriorating or doom. That is, the patient is not improving with the inotrope or mechanical support. And E, that is even deteriorating, and the patient need to undergo cardiopulmonary resuscitation or further treatment modalities. So different studies has been done in different studies. It has shown that the association between the SCAI shock stage and mortality risk, that is increasing the stage of the shock, the mortality increases. So the distribution in all these validation studies included from group stage A to stage E, but some of the studies, there are stage A and B are not included. Similarly, the sort of mortality was increasing as the stage of shock increases. That is, the mortality is highest among the stage E and lowest among the stage A. And some of the studies, there is no significant mortality in stage A and stage B. So the SCAI shock stage provided stepwise mortality risk stratification with the subgroup of acute coronary syndrome, myocardial infarction, heart failure, and those with and without cardiac arrest. Most studies classified the SCAI shock stage at a single time point, precluding the analysis of serial change in stage over time. And there are different variables that has been defined by SCAI shock stage in these validation studies. That is the clinical variable based on the availability of data. And so most of the study, 5 group of study, they have study specific SCAI shock stage criteria, whereas 2 groups have physician assessment of the stage. But some of them has prospective assignment of the stage by the heart team. The physical examination and invasive hemodynamic assessment was not included, not used in most of these studies because they have been retrospective data collection. And there was heterogeneous group, and there is no classification scheme in the same population for risk stratification. So these stage A to stage E, there are different variable, clinical variable, elevated lactate, that is more than 2, signifying that there is perfusion abnormalities, and more elevated level of lactate and low PS with need of multiple vascular pressures and mechanical support, and even cardiopulmonary resuscitation in stage E. So the SCAI shock validation study in patient with cardiogenic shock with and without myocardial infarction, in different studies, it has been shown that there is incremental but strong association between the shock stage and mortality. Even though mortality occurs in a lower stage of shock, the mortality rises when the stage of shock increases. Similarly, in patient with admitted patient in cardiac care unit or out of hospital cardiac arrest patient, the mortality increases as the stage of shock increases, and in hospital mortality also increase in a similar way. But sometimes if the patient survives at the time of admission, the chances of mortality post-discharge was also high according to these validation studies. So these studies also found out the modifiers, that is, the modifier, presence of the modifier increases the chances of mortality, like increasing age, systemic inflammatory response syndrome, acute kidney injury, non-cardiac organ failure, severe acidosis, congestion profile, high elevated pulmonary pressure, worsening of elevated lactate, non-ventricular fibrillation, cardiac arrest, and increasing stage of SCAI. All these modifier, if some of the modifier are present, then the chances of mortality goes higher. So from these SCI classification validation studies, it was found there are some of the shortcomings of the original classification. That is, sometimes it is difficult to differentiate stage B from stage C. That is, sometimes the lactate level may be normal, but the patient is in the stage of hypoperfusion. But sometimes the patient may be in the stage of stage B, but the lactate level may be increased. That is because of sometimes mesenteric ischemia or compartment syndrome. Similarly, sometimes there is difficulty in differentiating between stage C and stage D. That is, sometimes in some institute, they increase the inotrope, the single inotrope in the high dose, but in some institute, they use multiple inotrope, the patient do not respond. So cardiac arrest modifier clarification, because sometimes the patient has to be defibrillated for VTF, BF, brief CPR are given, and this should not be kept as a modifier of cardiac arrest. The only thing is that post CPR, if the Glasgow coma scale is less than 9 or the patient is in the stage of coma, not open command, those patients are said to be a risk modifier after cardiac arrest. Similarly, the age as a modifier, if the patient age increases, the chances of dying also increases, but there are too much of uncertainty exists in this, because as the ability of the patient to cope with the stress with increasing age decreases. So there are some key aspects in this classification, that is low risk and high risk patient in the same stage exist. That is, if a patient are in the lower stage and high risk of the lower stage has a higher chances of mortality than the low risk of the higher stage of the shock. So we have to incorporate revaluation schemes. That is, the patient need to be reevaluated time to time, so that the patient, improving patient comes to the lower stage and deteriorating patient goes to the upper stage, so that we can escalate and de-escalate the treatment modalities. Sometimes the cardiac arrest patient, those have a neurological injury or perfusion abnormality, those patients has a higher chance of mortality. And similarly, the age. And sometimes in some institute, there is no mechanical circulatory support. So those patients, as a stroke, has to be transferred to the primary shock center, where the mechanical circulatory support is available, that is in the half center. And similarly, identification of the CKS patient should be done at earliest, and treatment should be done as earliest. But sometimes we have to see that the possibility of survival should be greater in those group of patients, so that the reward of treatment is also good. And sometimes the transfer for fetal care is unregular high-risk patient do not change outcome, so that treatment should be discouraged in those contexts. And clinical decision-making for patient with cardiogenic shock must indicate not only shocks, but the etiology of shock, that is ischemic versus non-ischemic, acute and chronic, presence of reversibility organ failure, degree of congestion, and LV or RV or biventricular failure. So, and it also depends upon the shock phenotype, and we should consider the updated classification, whether the patient is an RV failure, patient in the RV failure or biventricular failure, or whether patient is dry or the patient is in state of wet, or if the patient is cold or if the patient is warm. That is, if the system, sometimes the systemic vascular resistance index is high with low cardiac index. So due to all these things, the 3-axis model need to be incorporated in the newer classification, that is severity, shock severity, phenotype and etiology, and risk modifier. All these things should be incorporated for the best management of the patients and cardiogenic shock. So the updated shock stage classification table, this table that is a bit different from the previous table, in which there are physical finding and bedside finding, and biochemical markers and hemodynamics. That is stage A, stage B, stage C, and stage D. In the stage A, the patient have normal JVP, warm, well perfused, lab parameters are normal, hemodynamics are normal. In stage B, elevated JVP, warm and well perfused, normal lactate, hypotension, tachycardia is there. So in stage C, the patient will have volume overloaded. The patient may be altered level of consciousness. The lactate level will be high. Sometimes the creatinine may increase. Tachycardia, hypertension, decreased cardiac index, increased pulmonary capillary wedge pressure. Similarly, in the stage of these, all these parameters are present, and patient with increasing level of inotropic support or mechanical support does not improve, then the patient goes in the stage D, where the lactate level is more than 8, pH may be less than 2, and those patients sometimes can need to be defibrillated, a patient collapse and need to be resuscitated with CPR. So revised SCAI shock pyramid, this is the newer form of the pyramid where there are different color to denote the different stages. And there is a modifier, that is cardiac arrest modifier with anoxic brain injury is considered in the newer updated pyramid of SCAI. So the classification and patient trajectory. Sometimes what happens is that during the treatment, the patient improves, but sometimes the patient deteriorates. So it is a dynamic process. If the patient improves, then the shock stage decrease, and if the patient deteriorates, then shock stage is reduced. So, in conclusion, a three-axis model of risk stratification in cardiogenic shock has been proposed to position the SCAI shock stage in context. One component of mortality risk prediction along with etiology, phenotype, and there are other risk modifiers should be considered. And this need to be considered in the newer classification. Similarly, the validation studies have underscored the correlation of SCAI shock stage with the mortality across all clinical subgroups, that is, including the cardiogenic shock without acute coronary syndrome, cardiogenic shock in patient with cardiac intensive care unit, and those presenting with out of hospital cardiac arrest. Similarly, the progression across the SCAI shock stage continues a dynamic process. That is, I already mentioned, the patient has to be evaluated time to time. If the patient's condition deteriorates, therapy should be escalated, and if the patient condition improve, then we can de-escalate the therapy. So we have to incorporate the new information as available, and we can increase the stage of the shock, or the patient stage of the shock increases, or sometimes the patient's shock stage decreases and the patient improves. So hub and spoke model for transfer of high-risk patients, including those with deteriorating SCAI shock stage, has been proposed. That is, spoke model means peripheral hospital, where the patient's condition can be treated with inotropes, but mechanical circulatory supports are not available. So those patients need to be immediately referred to the hub center, where the mechanical circulatory support and other modalities are available. And this has to be incorporated in the newer classification of shock, and cardiac arrest accompanied by coma. Inability to respond to organ stimuli, most commonly associated with Glasgow Coma School or 9, signifying anoxic brain injury. So this has been incorporated in the recent classification. Similarly, the SCAI shock pyramid and associated figure now reflect gradation of severity with each stage and pathways by which patient progresses or recovers. And in the newer classification, there is different color coding was given with a blue, dark blue with the stage A, and a purple to the stage E. And the lactate level and threshold has been highlighted to detect hypoperfusion. So these are the things that need to be considered in patients who have cardiogenic shock. And in cardiogenic shock, in SCAI classification model from A to E pyramid, from A to E, there are some changes as compared to previous. So thank you for the attention.
Okay, thank you, Dr. Porter's excellent talk. Now his talk is open for discussion. Is anyone from the web has any question? Even though I asked Dr. Porter, because what is a new reclassification of SCAI, this including some shock severity or phenotype and risk modifier. So is this new SCAI shock pyramid has been validated by reports from the literature?
Yes, I could not hear you.
Yeah, I may. Yeah, I ask you that about the SCAI pyramid. I mean, the new revised classification. Is there any paper to validate the new classification methods? Any clinical data to validate the shock, the pyramid?
Yeah, the new classification pyramid, it includes from stage A to stage E, and there are some risk modifier. Initially, there was if the patient had short brief period of cardiac arrest, those brief, and because the prognosis, if the patient who have VT and VF, we give shock in those patients, those things are not being incorporated. Only the patient have low GCL, Glasgow Coma scale less than 9, and does not obey the command, are being incorporated as the cardiac arrest modifier. And three axis model, including severity of shock, risk factors, etiology, and modifier. These three axis modifier are also being incorporated, and the hub and spoke. And similarly, the different color coding in the pyramid has been added as compared to the previous model.
Okay, because last year in Czech, there is a paper about the CI cardiologist working group. They define a new system for the shock classification, including the blood pressure label and the use of devices and the inotropic numbers. So what do you think about this new SCAI cardiogenic shock working group for the new classification of cardiogenic shock?
Maybe I can comment. Okay, go ahead.
I could not hear. Maybe the problem.
That there is a new paper published in last year in Czech. The data from the SCAI cardiogenic shock working group. They defined also ABCDE, but they have the hypotension defined by blood pressure, systolic blood pressure less than 90. And it defined the number of inotropic agent used or device used. So how do you think about this new classification for cardiogenic shock?
Okay, they have defined in terms of cardiac index. They calculate from the hemodynamic cardiac index less than 2.5 liter per meter square body surface area, and blood pressure less than 90 millimeter mercury, and with symptoms of shock.
Okay, thank you. So because time is, we now move on to the next topic. The next topic is the speaker is Dr. Jeremiah Gimarino from Philippines. Dr. Gimarino is CEO and a medical director, Palawan Baptist Hospital, Palawan, and also a clinical head at the section of cardiovascular imaging at the Baptist Hospital, Palawan, Philippines. The title of his talk is Invasive Hemodynamic Monitoring by Swan-Gang's Pulmonary Artery Catheter in Cardiogenic Shock, Value of Taylor's Shock Therapy. Let's welcome Dr. Geronimo.
Hello, good afternoon, everyone. First and foremost, I would like to thank the APSC for inviting
me to be one of the speakers for this talk, and also to the Philippine Heart Association for inviting me to represent our country in this cloud webinar with APSCs. Ugtong adlaw kanindong tanan. I am Dr. Jeremiah Marino, and I'm a cardiac intensivist practicing in the beautiful island of Palawan. So my talk for this morning, for this noontime, is about the standardized management of cardiogenic shock with or without cardiac arrest, and with invasive monitoring by Swan-Ganz pulmonary artery catheter in cardiogenic shock, the value of tailored shock therapy. I have no conflicts of interests with regards to this talk. So the objectives for this talk is, at the end of the session, audience will be able to appreciate the development and use of the pulmonary artery catheter and understand the hemodynamic parameters provided by the pulmonary artery catheter, and criticize the evidence of the PAC in terms of its endpoints in shock therapy. This is according to the U.S. Cardiology Review in 2022, this is the chain of survival in cardiogenic shock. So you have early recognition, early support, early MCS, or mechanical circulatory support, and early intervention. We need to be very keen in our monitoring and our management in terms of cardiogenic shock, because the mortality rate still remains very high, to more than 40%. So my talk is actually centers on pulmonary artery catheter, or the Swan-Ganz catheter, wherein the utility or the use of the PAC starts with an early support, and wherein we can get valid or valuable information from the PAC monitor. So before we proceed to the PAC talk, we must thank these two guys over here, this William Ganz and Jeremy Swan. They were the ones who invented Swan-Ganz catheter, also known as pulmonary artery catheter, in 1917 at Cedars-Sinai Medical Center. So the pulmonary artery catheter has these ports, the thermistor port, wherein this detects the change in temperature when you inject an injectate of 10 ml of D5 water. This is a proximal injectate, wherein this goes into the right atrium, also monitoring for the pressures in the right atrium. And at the same time, you can inject your medicines over this, or medications over this port. The PA distal is actually the one at the distal port, the yellow one, and there's a balloon inflation port, wherein you can, at the tip of the balloon, the tip of that port is a balloon wherein you can inflate it so that you can do your pulmonary capillary wedge monitoring. So these are the indications for pulmonary artery catheterization. First, it is indicated for heart failure, for shock, for post-myocardial infarction, for pulmonary artery hypertension, pulmonary edema. Also, we can use it for monitoring, which is still very common up to this day after open heart surgery or drug therapy, heart valve disease, and cardiomyopathy. This slide tells us about the various waveforms by which pulmonary artery catheter shows in the monitor. So in the upper part of your screen is the waveforms, and the lower part of the screen is actually where the tip of the balloon is actually inflated, or the tip of the balloon is located. So if the tip of the balloon is at the RA level, so this is the expected waveform, and if you move the balloon further, traversing the tricuspid valve and going to the right ventricle, so you will see these waveforms, it's all waveforms over here. And if you inflate the balloon and the balloon floats up to the pulmonary artery, you will get this waveform with the dichrotic notch. And if you inflate the balloon up to the capillary part of the main pulmonary artery, then you have these wedge waveform. If we get to inspect or dissect each of the waveforms, so this is the waveform seen in the RA or in the superior vena cava. So you see this waveform with a normal pressure of 4 to 12. Any increases in the RA waveform may indicate some pathologic abnormalities like severe tricuspid regurgitation, increased right atrial pressure, or even the presence of RA mass or RV mass. This is the RV waveform. The normal value is between 20 to 30 mmHg, and the normal diastolic pressure is between 0 to 5. And increase also may be brought about by the presence of RA mass and presence obstruction in the pulmonary artery, pulmonary valve, I mean. This is the PA waveform, wherein you see some dichrotic notch over here. The normal value is 20 to 30, and the diastolic pressure between 5 to 10, and the mean should be less than 20. And then it's the wedge PA waveform, wherein you inflate the balloon into the pulmonary artery, and then if in the absence of obstruction in the lungs, you will have this waveform. And this is actually a reflection of your left atrial pressure. So you can actually predict what is the pressure in the left side of the heart by doing a wedge form or doing a pulmonary capillary wedge form monitoring. So for example, if your pulmonary artery wedge pressure is between 80 to 20, you expect that there is mild pulmonary congestion. However, if your pulmonary artery wedge pressure is more than 30, you have fulminating pulmonary edema. So with that, you can actually, with these values, you can actually tailor fit your medications and as well as your mechanical circulatory device therapies, depending on these values. So these are the measurements of the pulmonary artery catheter waveform. So you can get CVP, the RVP, the PEP in pulmonary artery wedge. And all of these have clinical relevances in terms of pathologies in each of the chamber of the heart. Also going through, we can also monitor and deduce from the pulmonary artery catheter values the stroke volume, the cardiac output, the stroke volume index, and the cardiac index. And then also we can derive from a mathematical equation values that tell us about pulmonary vascular resistance, systemic vascular resistance, RV stroke work, LV stroke work, and even get blood from the distal port and get mixed venous oxygen saturation, which is actually predictive of adverse outcomes for patients in undergoing cardiac surgery and even heart failure and even sepsis. So these are the hemodynamic criteria of cardiogenic shock. So the thick cardiac index should be less than 1.8 in the absence of inotropes or vasopressors, or less than 2.2 in the presence of inotropes and vasopressors. The wedge pressure should be more than 15. The cardiac power output should be less than 0.6, and the pulmonary artery pulsatility index should be less than 0.1. If this hemodynamic criteria are met, you should also consider placing the patient for percutaneous mechanical circulatory. So these are in one of the studies by Garan et al. In JACC last November 2020, we have seen these the PEC utilizations. If you don't use PEC utilization, usually in the particular study, 18% of the population did not use PEC. 40% did a complete assessment by each presence of any one of the four of the following invasive hemodynamics: ASP, PADP, wedge pressure, and pulmonary artery saturation. And the complete assessment had all of these monitored, plus the presence of right atrial pressure. We'll go back to this figure in a while and see if there are any mortality benefit in terms of the SCAI staging in terms of cardiogenic shock. It's also the use of the pulmonary artery catheter in the presence of your vasopressors, inotropes, IABP, Impella, Candim heart, and VA-ECMO, of your MCS. So we see that there is increasing total cardiac power output across the line of your medical therapy as well as the mechanical circulatory support therapy. So the CPO, the cardiac power output, is actually one of the strongest predictors of mortality in patients with cardiogenic shock and heart failure. Now we go to the various evidences by which the pulmonary artery catheter is used in terms of heart failure and cardiogenic shock. Before, in 2005, Journal of Medical Association gave us this article, evaluation study of congestive heart failure and pulmonary artery catheterization effectiveness, or the ESCAPE trial. They have used or concluded in this particular trial the therapy to reduce the volume overload during hospitalization for heart failure and to mark improvement in signs of symptoms of elevated filling pressure with or without the PAC. Addition of the PAC to careful clinical assessment increased anticipated adverse outcome events, but did not affect overall mortality and hospitalization. So we see that this particular study actually did not support the use of PAC in terms of heart failure. Also, in 2013, one of the superstars or rock stars in the world of intensive care, Pulmonary, published his obituary published in the Annals of Intensive Care in 2013. the obituary pulmonary artery catheter from 1970 to 2013. And this review article actually stated that there is no evidence that the use of the pulmonary artery catheter has improved outcomes. That's why there is some certain debate among intensivists and cardiologists regarding the use of the pulmonary artery catheter. Because intensivists will say that we don't need pulmonary artery catheter to actively resuscitate patients hemodynamically with heart failure. But in terms of our cardiology counterparts, the pulmonary artery catheter still has a role in resuscitating patients with heart failure and cardiogenic shock. So we will be playing on the newest news and the newest articles and researches with regards to the pulmonary artery catheter in terms of its value in tailored shock therapy. So a journal with an article published in the Journal of American College of Cardiology, the standardized team-based care for cardiogenic shock, says that by Tirani et al. Said that use of right heart catheterization was associated with a 39 absolute increase in survival. So using right heart catheterization or pulmonary artery catheterization has actually a survival benefit in terms of resuscitating cardiogenic shock. Another article published in the Circulation Heart Failure by Thayer et al., the invasive hemodynamic assessment and classification of in-hospital mortality risk amongst patients with cardiogenic shock, says that pulmonary artery catheters were used to collect any hemodynamic data in 79% of the total study population, with both the right atrial pressure and the pulmonary capillary wedge pressure at 55%, or more than half of the total population. And they have seen in this study that venous congestion is common and identifies patients with cardiogenic shock at higher risk for hospital mortality. So using pulmonary artery catheter, they can actually predict which patients will be doomed to mortality. In this particular table, in that particular study, actually tells us a comparison between the survivors and the non-survivors. So in the hemodynamic parameter, tells us that the right atrial pressure, the pulmonary capillary wedge pressure, the cardiac output, the cardiac power output, and the cardiac and the mean arterial pressure are actually predictive of survival with significant p-values of less than 0.05. Another article published in the Journal of Intensive Care Medicine in 2020 talks about the current use and impact on 30-day mortality of pulmonary artery catheter in cardiogenic shock. And these are the results from the CARD-SHOCK study. So the authors found out that the use of the PAC was associated with aggressive treatment, but did not translate to a 30-day mortality benefit. But in that article, it was mentioned that compensated heart failure registry showed mortality benefit not limited to patients with persistent hypotension and need for inotrope treatment. Another article by Garan et al. In the Journal of American College of Cardiology and Heart Failure showed the complete hemodynamic profiling with pulmonary artery catheters in cardiogenic shock is associated with lower in-hospital mortality. So this is actually the figure that I showed you earlier. The blue one talks about that there's no PAC utilization. The red one shows a 40% of incomplete assessment using the PAC, and the 42% of the population showed complete assessment of the using the PAC. And here in this particular bar graphs, we have shown that all within the p-values are all within significant values of less than 0.0, less or equal to 0.05. And we see here that there is lowest mortality or overall mortality for patients with complete assessment of the hemodynamic parameters using pulmonary artery catheters, as well as SCAI stage D and SCAI stage E. So the conclusion of this particular study showed that the use of complete PAC-derived hemodynamic data prior to MCS initiation is associated with improved survival from cardiogenic shock. Another article was published, I think this was in 2020, the Pulmonary Artery Catheterization and Cardiogenic Shock Systematic Review and Meta-Analysis. This was actually in July, 2021. So this is the forward plot of that meta-analysis and showed this is the adjusted mortality at the longest possible follow-up. And it showed that the diamond here, which represents the estimated 95% confidence interval for the size of the meta-analyzed data, says that across a spectrum from cardiac surgery and etiology of cardiogenic shock not specified, tells us that cardiogenic shock favors the use of pulmonary artery catheter. There is not much evidence or benefit for among patients with acute coronary syndromes, because you can also do your coronary angiography and revascularization. But for those with cardiogenic shock not specified in those cardiac surgery, the use of the pulmonary artery catheter is still beneficial. Here's another article from the Journal of Critical Care published in 2022 last year. This entitled Prognostic Implications of Pulmonary Artery Catheter Monitoring in Patients with Cardiogenic Shock, to the systematic review and meta-analysis. So the forward plot tells us that this also favors the use of PAC across the studies from 2018 to 2021, that adjusted short-term mortality still favors the use of pulmonary artery catheter. Another study, the prognostic implications of pulmonary artery catheter monitoring, cardiogenic shock, it says that the conclusion of this study in 2022, the PAC was associated with lower incidence of short-term mortality in 30 days in cardiogenic shock fully adjusted observational study. Another meta-analysis published in the American Journal of Cardiology in 2022 last year shows us that this is the mortality outcome without the use of the PAC compared to the use of PAC. So this use of the PAC, right side of your of the one line over here, there is an odds ratio of a 1.5 increase in mortality for those patients who did not use pulmonary artery catheters. And the lack of hemodynamic monitoring through the pulmonary artery catheter in patients with cardiogenic shock was associated with increased mortality. So what are the key takeaways for this talk? So the cardiogenic shock is hemodynamically complex syndrome. And with that hemodynamically complex syndrome, we need to use our tools effectively and how to interpret these hemodynamic parameters so that we can resuscitate the patient in cardiogenic shock effectively and pull out our patient from mortality. And the use of the pulmonary artery catheter from shock has rose and fallen for the past 2 decades. But however, recent evidence shows that there is burgeoning evidences that support the use of the pulmonary artery catheter in hemodynamic resuscitation in cardiogenic shock through early and more accurate identification of cardiogenic shock phenotype, which can guide medical and mechanical circulatory support therapies. And there is now better proof for mortality benefit with the use of pulmonary artery catheter. More randomized controlled trials are needed to support the current data, because the meta-analysis actually showed retrospective trials and observational studies. And with that, I thank you so much for your kind attention. Thank you so much, everybody, for joining us this evening.
Okay, thank you, Dr. Semerino's excellent talk. Now his talk is open for discussion. So may I ask you, so you showed that about before 2013, there's a negative result of PAC use in patients with cardiogenic shock, but in recent years, there's a better result for PAC use in cardiogenic shock. Can you explain what's the reason?
Okay, so actually there's still up to this very day, there's still a debate between whether there is evidence for the use in terms of pulmonary artery catheter in cardiogenic shock, because there are still certain articles still does not really believe in the use of PAC. Because recently we have our peripherally inserted continuous cardiac output monitoring locally that can actually monitor for cardiac output and the other parameters that we need. However, there is certain degree the previous trials have a various mix of population. They mix both those who are in cardiogenic shock and in heart failure. So the results may not be very robust because of this varied population. However, meta-analysis showed the recent past 2 or 3 years tells us that if we only concentrate for patients with cardiogenic shock, there's a certain degree of benefit with the use of the pulmonary artery catheter. So you can actually derive certain values actually predictive of mortality. Short-term, usually a short-term mortality benefit. Still, it has benefit rather than no benefit at all.
Okay, the second one is we know that the PAC is an invasive procedure, and now we have in modern science we have a lot of non-invasive monitor to take care of the cardiogenic patients. So because with the SCAI class has 5 from A to E, so which class do you suggest PAC for the patient?
There was a study that I showed earlier that there's actually more benefit for mortality for patients with stage D and E. Actually, the studies actually showed us that the use of the PAC actually used for more for sicker patients and for those patients who need close hemodynamic monitoring. The overall mortality benefit for the use of PAC across SCAI stages actually still beneficial in terms of adjusted mortality rate. So still we can use it for patients and stage B, C, but more beneficial for patients stage D and E.
Okay, is there any question from the audience or from the other speakers? Okay, if there's no more question, we will move on to the next topic. So the next topic will be talked by Dr. Arifah Juga from Indonesia. Dr. Juga is a consultant cardiologist and a cardiovascular internist and interventional cardiologist at the Boracay Jawa Hospital, Sengha Royal, in Jakarta, Indonesia. And his talk, the title is Timing and Selection of Vasoactive Therapies in Cardiogenic Shock, Inotropes versus Inodilators. Let's welcome Dr. Juga.
Thank you, Professor Xu. Let me share my slide. Yes, first of all, thank you. It's an honor to speak in this session. It's expert in their field. So my topic is timing and selection of vasoactive therapies in cardiogenic shock, inotropes versus inodilators, and I have nothing to declare for this talk. So my outline would be first to rationalize the use of inotropic vasodilator. I think it's very important to understand the pathophysiology, and then I will discuss the evidence on inotropic and vasodilator, and then its role in the management of throughout cardiogenic shock. And I just like to share our strategy, and at the end is a summary of the whole talk. So it's mentioned that the cardiogenic shock is escalating stage from A to E, and then here it involves a change in hemodynamic, microcirculation, inflammation, and organ dysfunction. And it's time sensitive, just like a STEMI patient. So in this case, patient when it starts to a classical cardiogenic shock, which is begin at C, you can see there's already as a hypoperfusion, and in the beginning, and congestion and hypoperfusion. In the beginnings, probably if we can reverse that early, then we won't have any organ injury. But if there is a delay in reversal of this hypoperfusion, of course, it's going to impact on the microcirculation. And then once the microcirculation is impacted through inflammation and hemodynamic, usually the return of hemodynamic to optimal for microcirculation it usually doesn't improve the microcirculation that resulted in organ dysfunction and multi-organ failure. So the idea, I think, from this slide, I think we should agree that we have to restore hypoperfusion immediately by having a good perfusion pressure for the patient. And I'd like to propose a pathomechanism why we need to do it early, and what's the impact if we don't restore the blood pressure or the perfusion pressure early. Here it says once the cardiogenic shock is involved cardiac performance, then we need to involve early for inotropic, so to restore the perfusion pressure. So the microhemodynamic is not a compromise, because if the hemodynamic can return not compromised, then we probably from stage C we can go back to stage B. But if the return of the microhemodynamic is too late, then we have a hypoxia of the tissue perfusion, and that could cause early mortality. But if there is the microcirculations already fail, and then we manage to improve the microhemodynamic, then what comes after that is shears, which lead to infection, and then sepsis, and then multi-organ dysfunction. So that's why inotropic, and this thing is very important to have initial as an initial medical therapy in cardiogenic shock. The idea is to maintain arterial pressure for adequate tissue perfusion and increase tissue perfusion. However, the penalty is the increase on the most of the inotropic and vasopressor is the increase in myocardial oxygen, which also increase the incidence of ventricular arrhythmia, worsening ischemia. Therefore, it should be given at the lowest dose and the shortest time possible. And I think this is where the invasive hemodynamic monitoring, like the previous speaker have mentioned, is very important. And then the other is to integrate the clinical and laboratory hemodynamic findings to determine whether the response is positive with our appropriate vasoactive drug regarding the dosing and the titration. The clinical pharmacology and use vasopressor, I think there is, to simplify things, I think there is a vasoconstrictor and also inoconstrictor, which is norepinephrine, epinephrine, and dopamine. And the other one is inodilator. I would like to highlight the difference between those agents. One agent is worked through an adrenergic receptor antagonist. This is the dopamine, dobutamine, norepinephrine, epinephrine. And the other two from calcium sensitizer and phosphodiesterase inhibitor. And the mechanism for the adrenergic, of course, is through the beta and receptor. Here, if we see a dopamine, they have a lower dose, it acts on the dopamine receptor, and higher dose, it will be in the beta receptor. And the inotropic and vasodilatation arterial is at low dose, but once you get to the high dose, the vasoconstriction become more. And regarding the pulmonary vasodilatation, is usually neutral and a bit elevated. And there's quite elimination is within 2 minutes. The difference with dobutamine, they mostly work only on the beta receptor, beta 1 and beta 2, and has also an inotropic effect and a little arterial vasodilation. And high dose is also has a vasoconstriction, although it's not much. But regarding the pulmonary vasodilatation, at the lower dose, it's actually decrease pulmonary. It's actually causing a pulmonary vasodilatation. and higher dose, it will increase. This, I think this two information is important because it will affect your approach or your when there is also biventricular failure or is a right heart failure. In terms of norepinephrine and epinephrine, I think both is mostly a vasoconstrictor, especially in high dose, and epinephrine. I think we gonna look at these two vasoconstrictor. What is the better choice for cardiogenic shock? And also levosimendan as a calcium sensitizer. It has a arterial effect, like milrinone also have a vasodilator. So these both are inodilator and also increase the vasodilatation of the pulmonary artery. So this is also affect hypotensive. So I think first we have to, I'm gonna look at the trial on mixed cardiogenic shock. I think we can start by comparing in the SOAP2 trial norepinephrine and dopamine. This is in a population of mixed shock, and between norepinephrine and dobutamine there is no mortality difference at 28 days. However, dopamine have more arrhythmia, and then in acute myocardial infarction cardiogenic shock, mortality is higher in dopamine. And then for comparison between epinephrine and dobutamine and norepinephrine in also cardiogenic shock, but the exclusion in this case is acute myocardial infarction, so mostly heart failure cardiogenic shock. Here we find that the use of epinephrine is causing more lactic acidosis and also arrhythmia. And then Ulich and Lewis, this is a mixed cardiogenic shock. And the Ulich trial, this meta-analysis compare levosimendan and dobutamine. I think the short-term mortality is reduced with levosimendan, but long-term mortality, there's no difference. But levosimendan, there is a signal harm in other shock, other than the cardiogenic shock. And Lewis compare milrinone and dobutamine. There is no difference in mortality and time and inotrope failure, and also length of stay of the CCU. And there is an ongoing trial comparing milrinone and dobutamine in mixed cardiogenic shock, but also involving, I think there's an arm also in biventricular failure. And we shall await the result of this study. What about then the cardiogenic shock post-CABG population? In the cardiogenic shock post-CABG in SOAP2 trial, also comparing epinephrine and norepinephrine and dopamine, it demonstrates the advantage of norepinephrine. And then in Optima cardiogenic shock due to AMI, I'm sorry, this is cardiogenic shock AMI population, is not the CABG population. The title is wrong. I'm very sorry. And there's in this Optima study, there's a discontinuation or due to harm. So the epinephrine cause a refractory shock, which is higher, more than 4 times, and the trend and short-term mortality is also higher with the use of epinephrine in cardiogenic shock due to acute myocardial infarction. So I think this, and then the other one is cardiogenic shock, comparing when you started with norepinephrine, whether to increase the dose or add another one, another inotropic like dobutamine. So they're comparing once you initiate epinephrine, whether once the mean arterial pressure is not achieved, whether you increase the dose of norepinephrine or add another inodilators of dobutamine. And it looks at the efficacy on the microcirculation and macrocirculation, and also the safety tolerance. And we also shall wait the result of this study. And then this acute decompensated heart failure population. So this population, it's not cardiogenic shock, but it would correlate to SCAI cardiogenic shock stage B. So here is mostly a levosimendan study. First, compare with placebo in acute myocardial infarct with reduced ejection fraction, but no hypotensive. And between levosimendan and placebo, there is no risk increase of hypotension and ischemia. It's actually no difference. And also Revive 1 and 2, no symptom improvement in 24, to look at symptom improvement in 24 hours in patient with reduced ejection fraction, but no hypotensive. And it has a shorter symptom relief with the use of levosimendan, but higher atrial fibrillation. And last is a patient Survive study comparing levosimendan and dobutamine. There is no reduce in mortality. Levosimendan however, have a lower NT-proBNP in patient with a reduced ejection fraction, but not hypotensive, and also no symptom. And I think it's worth to mention there is a new myotropes, which is independent from the calcium mechanism. So the advantage is there is no effect in arrhythmia and also ischemia. It's called omega camtif and mecarbil. And the study showed that it relief compared to in 48 infusion and through 5 days in patient with ejection fraction less than 40%. However, there hasn't been a study on a patient with cardiogenic shock for these inotropes. And then from there we go the mortality predictor in cardiogenic shock. I think from the first finding that the cardiac power output actually can predict mortality, especially when it's below 0.6, and it's still till now, I think 20 years later, with the advancement of mechanical circulatory support, the cardiac power output still a predictor for in-hospital mortality. Even you can see on the right from recent study from Basir, this is the National Initiative for Cardiogenic Shock. It demonstrates even when you categorize between 0.6 below and between 0.6 and also 0.8 and greater than 0.8, and the number use of inotrope, you can see that with the increasing use of inotropes, the survival decrease regardless on the which cardiac output you started with. So this is another that demonstrated that actually the number increase of inotropes correlate with the in-hospital mortality regardless of the cardiac power output. And then the other is the use of inotrope using FIS score. Previously you just look at the number of inotrope and vasopressor use, but FIS score I think demonstrate more closely because it incorporate the dose of not only just the number of the inotrope or vasopressor use, but also the dose. So in here you can see from predicted in-hospital mortality and CCU, the FIS score can be used, and it's more sensitive than Apache and the serum lactate measure. For FIS score below 85, I think it's consistent that the lower the score, the probability for survival increased, and the higher the score, probability for survival also decrease. But once the FIS score go beyond 130, then it less predictive for patient who has an ECMO. So it just shows that the more that you use, probably you need a mechanical circulatory support to improve the outcome. This is the paper that demonstrates also the use in hospital mortality with the intensity level of therapy, looking at the number of drugs and also the number of device. So as the intensity level of support is being put on the patient, mortality also increase. This is another data that demonstrate how important it is to use vasopressor and inotropes according to the patient need in the shortest time possible. And we also need to realize that actually the vasoactive agents only a part of the standardized of the comprehensive approach to management of cardiogenic shock, because it's actually involve management in emergency department care, invasive monitoring, some sort of monitoring is invasive, probably have more data, but I think some sort of monitoring is important to use a vasoactive agent. As you can see, the more vasoactive agent you use, it will increase the mortality. And also management of cardiac arrest, mechanical circulatory support, ICU management, regionalized system of care, so there is no delay in treatment, LV assist device, and also shock research. Here you see that the predictor of outcome in National Cardiogenic Shock Initiative with the mandate to use Impella is the predictor is cardiac power output less than 0.6, also lactate greater than 4, and creatinine greater than 2, with the highest in the cardiac power output less than 0.6, with odds ratio is 8.27. We actually find a similar predictor in our population regarding there is a lactate over 4. It's actually the odds ratio in our population for mortality is 10.5, and for EGFR below 30 is 7.4. So this both, I think, demonstrate the severity of hypoperfusion, definitely increase mortality. And in the same National Cardiogenic Shock Initiative, it demonstrates that the predictor survival of 12 to 24 hours is once in lactate is less than 0.6 and lactate is more than 4 and cardiac output less than 0.6, the survival only 31%. But if you can achieve lactate less than 4 and also cardiac output greater than 0.6 in the first 12 and 24 hours, the survival is 25%. So this is again demonstrate the importance to maintain perfusion pressure in patient to increase their survival. So if you see the National Cardiogenic Shock Initiative, it's installed shock protocols, and with the shock protocols, they have improved the outcomes as you can compare to other trials. Shock, IABP Shock 2, culprit shock, and the last one is the National Cardiogenic Shock Initiative. The survival is the highest in the National Cardiogenic Initiative, 7.2, despite the blood pressure is lower than the rest of the study, and also the lactate is higher than the rest of the study, which is 5.3. And if we look at compare it to the previous mortality actually the mortality is very impressive. It's only 28% in the cardiogenic shock population. And they attribute this success by proposing the best practice by deploying a mechanical circulatory support pre-PCI, which is achieved in 74%, and door to support within 90 minutes with mean 85 minutes, and 90% achieve telemetry flow, and 92% usage of swan guns, and able to maintain 0.6 greater than 0.6 cardiac output, 62%, and survival at discharge, as mentioned before, is 72%. So, in summary, inotropic pressure in cardiogenic shock is to rapid restore pressure. Norepinephrine is safer than dopamine, vasopressin, epinephrine, and lower risk of atrial arrhythmia. And rapid restore of stroke volume, you can use dobutamine as initial therapy, and prebutamine for low cardiac output and preserve perfusion pressure. And for dopamine and epinephrine is not considered for first-line therapy, as dopamine compared to norepinephrine associated with increased 28 days mortality, higher number arrhythmias, and epinephrine led to increased higher level of lactate in small randomized study. Thank you.
Okay, thank you, Dr. Suzuka's excellent talk. Now his talk is open for discussion. Is there any question from the audience? Also, other speakers? Okay, no. Okay, let me ask you, Dr. Juga. We know that there are two major phenotypes of cardiogenic shock. One is heart failure, and the other is myocardial infarction. So for these two kinds of phenotype, which inotropic agent or vasopressor would you prefer for different phenotype?
Okay, I think that's the mentioned in the data. Definitely, if it's acute myocardial infarct, you avoid the use of epinephrine. But I think epinephrine also demonstrate a higher lactate in mixed cardiogenic shock. So in general, I think it's still the first you use epinephrine to maintain perfusion pressure, and then if there is a need to increase the dose, it's not backed by the evidence yet. It's still in study. I think what we do is we put another inotropes instead of increasing the dose. And I think the most important thing is knowing the effect of each the pharmacokinetic or pharmacodynamic of each of the vasopressor of inotropics, and we use it according to the data from hemodynamic parameter that we get from our either invasive monitoring or non-invasive monitoring.
Okay, thank you. So any question from the audience? Yeah, gentlemen, there's a question? No, okay, because we know that no epinephrine prolonged use can induce, peripheral vasoconstriction, cause cold extremity, and mainly increase the K level. So how long would you suggest the use of the norepinephrine?
How long is?
Yeah.
Okay. The thing, I think from the pathophysiology, we know that the longer that we not restore the blood pressure or the mean arterial pressure, and we get that this inflammation that causing actually vasodilatation. So how long you need to use the norepinephrine? I think we use it to a target of systemic vascular resistance between what we do is between 800 to 100. And another thing, the first 24 hours, based on what we find and what they find in the National Cardiac Shock Initiative, if we cannot maintain cardiac power output more than 0.6 in the first 12 to 24 hours, then we should escalate to mechanical circulatory support, stronger mechanical circulatory support, instead of just relying on the inotrope or vasopressor.
Okay. Any question from audience? Okay, please. No, okay. So you mentioned that the myotropes, myocardial machine activators. What do you think about the future of this kind of drugs for the cardiogenic shock?
Well, as their advantages, there is no arrhythmia and no myocardial consumption. I think it's very promising for cardiogenic shock, especially cardiogenic shock with ischemic acute myocardial, due to acute myocardial infarction. But of course, it still need to be demonstrated in a study.
Okay, thank you. Again, then we move on to the next talker. The next speaker is Dr. Naoki Tadokoro from Japan. Dr. Tadokoro is a consultant surgeon at the Division of Adult Cardiac Surgery, National Cerebral and Cardiovascular Center, Osaka, Japan. And the title of his talk is Timing and Selection of Mechanical Circulatory Support in Cardiogenic Shock, Axial Flow versus centrifugal flow. Let's welcome Tadokoro.
Good afternoon. My name is Naoki Tadokoro. I'm a cardiovascular surgeon and I work at the National Cerebral and Cardiovascular Center in Japan. I will give a presentation on timing and selection of mechanical circulatory support in cardiogenic shock. Before I begin today's presentation, let me emphasize a key point of MCS management. The purpose of mechanical circulatory support in cardiogenic shock is to promote rapid recovery of the systemic circulation and reduce the cardiac workload. To achieve this, it is important to establish adequate circulatory support and achieve left ventricular unloading. According to the 2021 ESC guidelines, short-term MCS is classified as Class 2A in cardiogenic shock, which is higher than the use of inotropes. However, if hypertension and organ dysfunction do not improve with short-term MCS, invasive MCS, such as LVAD, should be considered. Therefore, the key is how to improve systemic circulation with short-term MCS. How does using VA-ECMO affect the heart? It is an increase in cardiac load due to increased afterload. It can be seen from the pressure volume loop. The left figure shows flow-dependent increase in end diastolic pressures. This enlarges the heart and leads to pulmonary edema on chest X-ray and elevated PA wedge pressure. Before this happens, afterload reduction and LV endoling should be performed. Considering the principles of MCS, ECMO alone provides adequate circulatory support. In contrast, the flow of ECMO loads left ventricle. When the left ventricle distension is observed after the ECMO insertion, non-invasive measures such as decreasing ECMO flow, using diuretics or inotropes, and adjusting ventilatory settings are used first. However, their effectiveness is often limited. However, let me say this. We should not reduce the ECMO flow, because this could lead to a worsening of systemic circulation and organ dysfunction. How do you unload the left ventricle while maintaining sufficient ECMO flow? There are three main methods. The first method is the percutaneous insertion of the impella through the femoral or axillary artery. Other methods are direct drainage from the left atrium or left ventricle. In particular, ventricular assist device placement, where a cannula is surgically inserted into the left ventricle, is invasive but provides strong LV unloading. When should we consider left ventricular unloading? The preferred timing is when echocardiography shows a smoke-like effect, indicating a left ventricular blood stasis, along with closed aortic valve findings, and when right heart catheterization shows elevated pulmonary capillary wedge pressure. From the observational studies to examine the efficacy and safety of left ventricular unloading, left ventricular unloading was associated with decreased mortality in adult patients with cardiogenic shock treated with VA-ECMO. However, in the absence of prospective randomized data, the left ventricular unloading may be. In terms of pump design, Impella is a coaxial pump, which has a motor-driven rotor that directs flow along a path parallel to the axis of the pump, whereas the other MCS uses centrifugal pumps that move liquid through centrifugal force. Impella is a small catheter-based pump that is inserted peripherally and into the left ventricle. The maximum flow rate of the device ranges from 1.5 to 5.5 liters per minute, depending on its size. Centrifugal pumps can be used for both central and peripheral support. With a sufficiently large cannula, it is possible to support up to 8 liters per minute. We will demonstrate a hemodynamic simulation of failing hearts, both before and after the introduction of the Impella. Following the initiation of Impella 2.5, the left ventricle size is reduced and end-diastolic pressure decreases. With the more powerful Impella 5.0, the left ventricle size is further reduced and the pressure varying loop shifts towards the left. From the ELSO registry for adults receiving peripheral VA-ECMO from 2010 to 2019, the proportion of PVAD, that is Impella cases, rapidly increased over the final 3 years of the study. Among adults receiving VA-ECMO, the mechanical unloading strategy was associated with lower in-hospital mortality despite increased complications, including hemolysis and cannula site bleeding. The similar results have been obtained in other reports. From the multi-center cohort study, the combination use of Impella and VA-ECMO was associated with lower mortality in patients with cardiogenic shock. The breathing complications and hemolysis occurred more frequently in patients treated with Impella. When is the preferred timing for Impella installation? In a step-analysis, early LV unloading followed by VA-ECMO, when the Impella was implanted before or shortly after the VA-ECMO, had a persistent association. Listed below are several contraindications and important notes to consider regarding the use of Impella. These contraindications should always be kept in mind. In particular, intracardiac or aortic thrombus can cause malfunction of the Impella. And if someone has really bad lung congestion, using Impella could make north-south syndrome worse. These factors can impair the recovery of cardiac function. This is our institutional strategy for treating patients with cardiogenic shock. We promptly switch to central MCS strategy in cases of a closed aortic valve, insufficient ECMO flow, ECMO complications, or contraindications to Impella use. If these are not present, we will promptly initiate Impella. We also switch to surgical MCS for a patient with poor recovery of cardiac function or multi-organ failure, even when the patient is receiving ECMO support. In short, we are aggressively converted to a central MCS. To summarize up to this point, the presence of left ventricular unloading enables sufficient free ECMO flow without concern for the heart. Introducing Impella for a cardiogenic shock carries a risk of complications, but early intervention within 2 hours is crucial for improving survival rates. There are cases where Impella is not suitable, and in such cases, invasive mechanical circulatory support should be considered. What are the advantages of central MCS? There is antegrade flow, which can supply oxygenated blood when combined with ECMO. The significant difference between extracorporeal bed and Impella is the size of the left ventricular cannula. The larger size of the LV cannula allows for stronger LV unloading. Surgical procedures, such as tricuspid valve repair, can be performed concomitantly if necessary. Unlike Impella, there is no concern for device-related aortic valve regurgitation, as the aortic valve is not passed through. Furthermore, it has high durability and allows for rehabilitation. However, they often involve more significant bleeding risks, systemic infections, and cardiac tamponade. By surgically implanting a bed, it is possible to use large inflow and outflow cannulas, allowing for a variety of configurations. Here are the basic patterns shown, depending on the severity of right heart failure. In some cases, right atrial drainage may be added, or a short-term LVAD may be implanted. We call this temporary biventricular support. In acute myocardial infarction or fulminant myocarditis, a durable long-term LVAD is installed from the beginning. We will now show a surgical video of biventricular assist device implantation. The cardiac function is visibly very poor. After establishing cardiopulmonary bypass, the left anterior descending artery and diagonal branch are marked, and then the site for LV cannula insertion site is determined. After attaching the cuff, the left ventricle is opened, and a 28 French LV cannula is inserted. And let out of the body. The outflow graft of the LV is then attached to the ascending aorta, and the outflow graft of the LV is also attached to the main pulmonary artery. Finally, a centrifugal pump outside the body is used to establish BiVAD. What are the differences between peripheral and central ECMO? Raffer performed a meta-analysis that showed no difference in all-cause mortality between peripheral and central cannulation. However, this study did show a significant increase in the risk of bleeding and the need for continuous renal replacement therapy in centrally cannulated patients. However, given that the more severely ill patient requires surgical MCS, it is reasonable to assume that appropriate MCS selection would have produced comparable results. Finally, we would like to present a brief case. The patient was a 59-year-old man diagnosed with fulminant myocarditis. After receiving VA-ECMO and Impella CP treatment for 3 days, he was transferred to our hospital. His peak CKMB and troponin T levels were extremely elevated, and he had developed worsening kidney and liver function. Despite receiving adequate ECMO support, the right heart catheterization revealed a high wedge pressure of 22 mm mercury. On electrocardiogram, we can see only P wave. On echocardiography, LVDD and DS are 39 and 39 mm. There was almost no cardiac contraction. Impella CP was inserted. And also, there is moderate aortic regurgitation was observed due to Impella. The patient suffered from biventricular heart failure and Impella-related aortic insufficiency, making it difficult to provide high flow support with VA-ECMO. Therefore, a surgical bypass conversion was performed. After 3 months, the left ventricular assist device was switched from an extracardiac valve to an implanted valve. The patient heart remains in asystole, but has been supported by the system for 3 years and is still awaiting a heart transplant. To summarize to this, a combination of VA-ECMO and Impella can provide substantial circulatory support and LV unloading. Invasive MCS strategies using LVAD and central ECMO provide further long-term and stable circulatory support. Stable LV unloading is important for the stable management of MCS, even in patients with severe cardiogenic shock. Standardized MCS management may improve the outcome of each strategy. Thank you very much for your attention.
Okay, thank you, Dr. Tato Kodo's excellent talk and a
Thank
good
you.
chance to set the nearly fatal case to survive. Yeah, that's excellent speech. And we have a question for anybody from the audience. It's no, may I ask you first question? We know that IABP is also important mechanical support. So, but the importance seems to be decreased because the guideline did not suggest the first line choice. So, how do you suggest the IABP use in patients with cardiogenic shock?
Thank you for your question. IABP has been decreasing now because of the impaired popular LV support, but the first choice for the IBP is now very important pre-cardiogenic shock patients. So in our hospital, we firstly implemented IBP and VA-ECMO first. Then when we see the aortic valve closure sign or smoke-like effect sign, we convert it to Impella now. So IB is not so important, but it is very important to support patients.
Okay. And the executive is the Impella is a very good device for cardiogenic shock, but it's more expensive than IBP. So what's the condition Impella could not be used? I mean, is any contraindication for Impella?
Contraindication of Impella was, as I mentioned, such as severe aortic regurgitation or aortic dissection or LV thrombus. So if you insert an Impella to the severe aortic regurgitation or thrombus LV, the Impella easily malfunction that leads to failing LV support. So I don't recommend you to use.
Okay, We know that the prolonged use of mechanical support could increase the breathing or blood clot. So what time is to winning the mechanical support, which you just said, when the device could be weaned?
Thank you for your question. And the breathing risk is a very important to consider. But from my experience, we try to waiting for an Impella when patient was fully medicated within 2 weeks. If patient have a very severe bleeding, we convert it to central MCS that is less bleeding in a canal site.
Okay, thank you. There's no any question from the audience or speakers. Now we move on to our last topic. Okay, thank you, Dr. Tadokoro Arken. Okay, now the last speaker is Dr. Yan-Hong Liu from Taiwan. Dr. Liu is a physician staff at the section of cardiology, cardiovascular center, and also director at the Animal Center, Far Eastern Memorial Hospital, New Taipei City, Taiwan. And the title of his talk is Emergency Management of Cardiogenic Shock in Out-of-Hospital Cardiac Arrest, OCA, Early VA-ECMO and Early Active LV Unloading. Let's welcome Dr. Liu.
Thank you, Professor Xu. And the first part of my speech is early VA-ECMO in OCA. And despite many advances in the treatment of heart disease, up to 1/3 of all patients with acute manifestations of heart disease do not reach the hospital after cardiac arrest. And only 8 to 10% of patients with OCA survive. And predictors of the OCA patient include shock reason, PCI, and hypothermia, acute coronary syndrome, and neurologic recovery. In our recent study, including the past 9 years in the OCA patient in our hospital, we found that the OH CPR, longer CPR duration, acute myocardial infarction are the poor prognosis of survival of OCA. By contrast, patent coronary arteries, shock reason, including PT and PF, and ST elevation myocardial infarction are good predictors of OCA patient with after RUSC. And what about the role of corporal CPR in the OCA patient? Even among patients with shock reason, up to half will have ventricular fibrillation.
Excuse me, Dr. Liu.
Yes.
Your slide is in the editing mode, not the full screen. So it's still on the first slide.
Oh, really? Not in the...
Yeah, you need to make a full screen in the presentation mode. Right now we are watching your editing mode, not the presentation mode.
Hey, but now it's in the full screen.
You're using a dual screen. The dual screen, there's a button you can switch between the presentation mode and your.
Let me see.
Yeah.
You mean to control? Can you see this slide?
You can use
still the same.
Check your lower panel. You can use PowerPoint. The full screen.
PowerPoint.
Yeah, you already make a full screen, but your full screen you are sharing your editing mode, editing screen, not the presentation screen.
Editor screen.
Yeah. So we can't see the full. We only see your editing mode, which you.
Yeah. Let me see.
对了，就是他总医师，总医师把它戳破血管了。
对，好，科也回复了，就先暂时还没有回啦。
OK， 好。对，
我看抽血那些。
哦 ，OK。
So, but I use the full screen, but you cannot see the full screen.
Yeah, we can't see. We only see your your editing PowerPoint screen, not your presenting screen. There's a, if you stop sharing and share
I
again.
Stop sharing. I stop sharing.
Yes. And then you can just then you pick up the screen.
Okay, I can.
Display.
I pick up the screen.
Yeah, then we can see your full screen. Please stop and share again.
Yes, I show you that. And can you see the new the slide?
Sorry, still on the very beginning slide, which is also on the editing mode. You may stop sharing first.
Stop sharing.
And try, then try again. But before you click the button, make sure, and pick the. Okay, it's coming still, but try make a presentation.
Okay,
on your lower.
Sorry, I keep making the presentation. And for the ECPR, if among patients with a shock reason, up to half will have ventricular fibrillation that is refractory, a factor that pertains a poor prognosis, particularly related to an organ ischemia. And one strategy that has been proposed to limit an organ ischemia in patients who have ventricular fibrillation that is refractory to CPR, and deterioration is ECPR. And in the AHA statement published in the Circulation 2019, they found that in the refractory ventricular fibrillation or passive SPT in OCA patients, there is high prevalence of severe coronary artery disease. And using the ECPR program, the survival rate is about 2.244, better than the national average. And in the past observation study before 2000, the
Sorry,
burden
Dr.
of
Liu. Sorry,
yes.
Dr. Liu. Your slide is still on the page 6. When we didn't see it's forward.
Yes, I tried it, but it didn't come to the new slide.
你把它变成前荧幕啊。
Yeah, already. He got a two screen. Are you using two screen PC?
No, I use only one screen. PC.
Yeah, but when you share the screen and you need to pick up the display screen, which means is a full screen instead of the editing screen. Right now, I'm watching your editing screen, and you are fixed on the page 6. But okay. So, yeah, if you can, or another way, you just keep the left part of the screen, and you make the next one, so we can see the full. So we can see at least which slide you are talking.
So, can you see the slide? No.
We can see the editing, which means with the other slide on the left and your slide on the center.
And
yeah, you can make a further. Can you make movie?
Yes. Can you see the slide?
Observation starts. Yeah.
Yes, observation study.
Okay, if you make sure you go to the next one.
Yes.
Okay. Thank you.
Sorry. Yeah. Okay. And the emergency of advanced perfusion reperfusion strategy and early deployment of VA-ECMO and PCI when needed have shown promising results and have been associated with 2.244 increase in survival in observation study. And in the year before 2018, the ECPR for refractory OCA may improve outcomes in carefully selected patients. However, the evidence is not the evidence is not enough. And the first randomized trial for the OCA patient is a ARREST trial published in 2020 in Minnesota, USA. And the inclusion plan is OCA and refractory VF, no RAS after 3 shots, and autonomic CPR. And estimated transfer time shorter than 30 minutes. And the primary outcome is survival to hospital discharge. And we can say that the study is early termination, and each group is only 50 patients. And the hazard ratio is 0.16. But because the number is very limited, but this is the first randomized trial in the single center. And the second OCA trial is a Prague OCA study. It is a single center randomized clinical trial in Prague, and it includes a patient with venous OCA of presenting cardiac origin without RASC. And the primary outcome is the survival with poor neurology outcome. It indicates a poor performance category 1 to 2 at 180 days. And we can see that there is no difference in the invasive strategy and standard strategy. But we can see there is a trend favor the invasive strategy, but the p-value is not significant.
Excuse me, Dr. Liu, your slides still not moving. Right now we are watching the one which is observation study. But can you make the screen you are sharing? There's on the lower right corner. There's a full presentation button. I think you can push.
Yes, I use a full presentation button. But
yeah, but
I don't.
Interesting. We only watch your. Okay, now it's moving, but. It's early extra. Is that one? Yeah.
Yes.
We are watching that one.
Yes,
yeah.
Another inception trial. And it's a multi-center randomized control trial in the Netherlands, and include the OCA with bystander CPR, initial ventricular arrhythmia, and NORA within 15 minutes after CPR. And the primary outcome is survival with favorable neurologic outcome at 30 days. And there's no significant difference between the eCPR and conventional CPR case. The odds ratio, the p-value is not significant. And comparing these three studies, the first study, the arrest enrolled a very modest sample size, only 30 patients, and it's only single center study, but it's a premature termination. And similar to inception trial, the Prague trial showed that eCPR didn't significantly improve outcomes as compared with conventional CPR. And this result, the result of all these three randomized trials show a pneumonologic advantage in their respective primary outcomes in favor of eCPR as compared to the conventional study. And the larger trials are needed for the statistics are necessary to capture and any benefit associated with eCPR as compared with the conventional CPR. In addition to the eCPR, there's another study presented in the AHA this year, the ECMO CS trial. It includes the immediate ECMO to treat people with cardiogenic shock, and there is still no significant difference in the ECMO therapy and compared to the conventional therapy. So in the at the present there's the ECMO for the OCA patient and also for the cardiogenic shock. The evidence is still lacking. And in by Professor Lin Junli, it conduct a new type A OCA protocol guideline. In conclusion, we subjected the OCA, the ECMO CPR for the indication is for the venous arrest, PTFF as initial rhythm, and by standard CPR less than 5 minutes, and failure to RASC after CPR over 15 minutes, and also the age is less than 80 years. And the next topic is the early active LV unloading in OCA. And before is the Dr. Cardiogenic has presented most of this data, and I just show you some evidence. And we know that the VA-ECMO affected restore systemic blood flow in patients with cardiogenic shock by potential deteriorating effect on the LV. And VA-ECMO increased LT load pressure and LV afterload, which can also lead to the LV distension, especially if there is any LT pump incompetence. In the early start, there are no randomized study comparing the conventional ECMO and LAPA ECMO. And we can see that after the hemodynamic after LAPA ECMO, we can see that the mean right atrial pressure decreased and mean pulmonary artery pressure decreased. And we can also see that
sorry,
cardiogenic.
Dr. Dewey, your slide is not moving. It's still fixed at the inception try.
Yes, I tried. I think there's something wrong in the computer.
Not,
and you can see,
yes.
Yes.
Please go ahead.
Okay. And we can see that in addition to LAFA ECMO, there's other measures. For example, the percutaneous transaltic venting, the percutaneous transeptal venting, including transeptal mitopuncture, balloon septostomy, breast septostomy, and transeptal cannulation, transpulmonary venting. And also the percutaneous direct, including the Impella, just mentioned before. And we can see, and for example, we can see that in one of our patients in the baseline, the OCA patient with RUSC, and after the atrial septostomy, the pulmonary edema improved day after day, and we remove the ECMO after 6 days after the ECMO insertion. And for the for the indication for the ECMO, for the LAFA ECMO, and the echocardiograph, if the echocardiograph shows a dilated and hypocontracted LP set within LP, and LP remains close throughout the cardiac cycle. And although swan guns or cardiac cars reveal wedge pressure greater than 25 mmHg, and severe pulmonary edema or refractory ventricular arrhythmia, which is just for the LAFA ECMO. And for the effect of LP decompression in VA-ECMO, including reducing PCWP, improving pulmonary edema, reducing LA pressure, improving ECMO output and LV ejection fraction, decreasing LV distension, and improving ventricular arrhythmia refractory medical arrhythmia. At our hospital, the first case in our hospital to do the LAFA ECMO is on 2013, and it's in the peripartum cardiomyopathy with cardiogenic shock and high LP and diastolic pressure. And the first LAFA ECMO in OCA patient was performed in 2015. And now for the PF with OCA, we do the total LAFA ECMO is 32 cases, and the cases is increasing in number. In 2022 at our hospital, there are about 600 OCA cases, and we perform ECMO in 33 of these cases. About half of them survived, and the LAFA ECMO was performed in 14 cases, and 7 cases of them survived. Of course, the LAFA ECMO was performed in the most severe cases, and the LAFA ECMO, it seems that the survival rate of the LAFA ECMO is similar to the conventional ECMO, so indicate that it likely to improve survival rate. And we also saw that LAFA ECMO improves pulmonary edema, improve ECMO output, and decrease LV distension in most cases. And this is the indication of the LAFA ECMO suggested by new type A OCA total care guideline by Professor Lin. The indication of LV decompression is refractory VT-VF, non-opening of LV valve, and pulse pressure of less than 10 mmHg, and severe LV dilatation and global hypokinesia, and severe pulmonary edema. And the contraindication of LV decompression include ventricular septal defects, free wall rupture, severe mitral regurgitation, and severe LV stenosis. Thank you very much for your attention.
Yes, thank you, Dr. Liu's talk. Although we cannot find a slide.
Sorry.
So I have a question that you show the more survivors in your hospital with LAFA ECMO for OCA, but the New England Journal of Medicine this year, the ECMO CPR and the conventional CPR is no different for the survival. So did you have the cost effectiveness for use of this kind of device for your clinical practice? Because in Taiwan, the ECMO is free, reimbursed by the National Health Insurance. So in other countries, ECMO may not be reimbursed by the company, by the country. So what do you think about this kind of device for these OCA patients?
Well, because we do not do the randomized clinical trial, but in our practice for the OCA patient, we see that in the patient with intractable ventricular in the intractable ventricular rhythm or the severe cardiogenic shock, the ECMO provide the much better hemodynamic support. And also, if the patient have the severe pulmonary edema or the high LV and diastolic pressure, we added the LA decompression, and we can soon see that the fluid spilling subside and pulmonary edema resolve very quickly. So in our practice, we saw that in the selected patient with refractory PTPF and witness OCA, I think ECMO ECMO support very important hemodynamic support for this patient and may improve the survival. And we also said that the NAFA ECMO should be performed as soon as possible if we see that there is severe pulmonary edema or high LV and diastolic pressure, or for example the severe fluid sputum in this patient.
Okay. Another question is what kind of criteria do you use to use the ECMO for OCA?
At our hospital, mostly we choose for the refractory PTPF and also cardiogenic shock in the witness OCA patient, and also the CPR duration is less than 40 minutes.
Okay. Okay, is there any question from the audience? If there is no more question, now we will close this section. I hope that after today's webinar, you will update your knowledge on cardiogenic shock and help your clinical practice for patients with cardiogenic shock. And thank you, everybody, for the participation of this webinar. Thank you, everyone. Bye-bye.
Right. Thank you. Thank you, Professor.
Okay, bye-bye.
Bye.
Bye. Thank you.